Hello, everyone. This is Alraies CVI 2022 in Denver, Colorado. I'm really privileged to have my friend and colleague Rahul Sharma after many years coming back against CVI 22. Rahul, you have a very interesting and Watchman case for LA closure presented tomorrow. So tell us a little bit about the case.
Yeah, so actually it's an amulet case of left atrial appendage closure. And it's a case where, without giving too much away for our friends tomorrow, but basically on several occasions, maybe a dozen occasions over the last 2 to 3 years, I have done left atrial appendage closure through an existing congenital natural PFO without performing transeptal puncture.
Yeah.
I have done it with Watchman devices, both the 2.5 and Watchman Flex device, and I've now also done it with the amulet device using their new Amplatzer steerable left atrial appendage sheath, which is the delivery sheath for the amulet. So with these, dozen or so cases of experience, I wanted to show one such case that I recently did, and so that's what I'll be talking about. And the idea, just to put a disclaimer, left atrial appendage closure should be performed through an infraposterior transeptal puncture or some modified transeptal puncture depending on your atrial appendage anatomy and angle. Using a PFO for left atrial appendage closure is not a recommended or routine technique, but it's something that has been done, something I have been able to do successfully, and just wanted to show a little provocative topic. Sure. A case on this topic.
Yeah, and so in terms of the location of the PFO, usually sometimes as structurals, I'm not claiming as one, you would like to have, as you said, posterior and inferior, but if the PFO not favorable.
The wrong location. Yeah, so I have done quite a bit of PFO closure in the last couple of years, and one of the things I noticed is that every time I cross the PFO for PFO closure in appropriate indicated patients, the wire always goes to the left atrial appendage. In fact, sometimes I have to manipulate the wire to put it in the left upper pulmonary vein where I normally would want to park it for a PFO closure. And when I started seeing that time after time, I started wondering, what if certain straightforward, quote unquote, straightforward left atrial appendage closure cases could be done safely through a PFO. And so I basically started doing it, in very select hand-picked scenarios of LAA closure, and found it to be very, essentially predictable,
nice.
Not complicated,
Sure.
and did not require a separate, transeptal puncture site. And at the end of the case, as you pull the sheath back across the PFO, it somewhat returns to its normal position, its normal patent position, and has minimal residual shunting as it did at baseline. So I have developed a certain level of comfort in these handful of cases that I've done, and felt that it has worked well. But you're right, it's in the completely wrong location, generally speaking, for LAA closure. But I think one of the provocative aspects of the case, or a question to pose to the audience or to the community at large, is in the world of steerable left atrial appendage sheaths, might you be more prone to using the so-called wrong location of a PFO to still successfully close the left atrial appendage? So, strictly speaking, I do transeptal puncture for almost every LAA closure or mitral case that I do, but in certain cases have used PFOs successfully. And the question to the community is, is this something that could be done from time to time?
Awesome. And now you close the appendage with amulet. Would you protect this patient from cryptogenic stroke to close a PFO on the way out?
Yeah, so obviously this is a data-free zone. There's no guideline on doing anything like that. I have not, in the majority of cases, I have not closed the PFO. There was one case where I did left atrial appendage closure through a PFO, and I saw what was pretty clear, convincing bidirectional shunting at the end of the case. It was a larger PFO with a significant diameter and size, and I felt compelled to close the PFO at the end of that case. But that is not something that I would routinely do. And I think one of the benefits of using the PFO, or at least for me conceptually, is that this is a naturally open door. You're going through it, and if everything has gone well, you should not have disrupted its architecture in any way. So closing it, if it wasn't indicated before in an AFib population, then it shouldn't be indicated after you deploy the left atrial appendage closure device. So generally speaking, I have not had to do that. but that's an interesting question.
Now, about the amulet, I mean, what is the anticoagulation regimen after amulet? I know there's some data saying...
Right. So the amulet device, which was compared to the Watchman device in the amulet pivotal IDE trial, looked at a variety of different anti-thrombotic therapies after device implantation. The FDA approval for the amulet device allows for 6 months of dual antiplatelet therapy with aspirin and Plavix after device implant, which is an on-label strategy after amulet. So for all of my amulet cases, I put patients on 6 months of aspirin and Plavix. I have not anticoagulated a single amulet patient post-implant. I have just done 6 months straight of DAPT and have not had any issues.
That's great. Well, wonderful case, innovative, as you said, and it's a pathway you can use in the future for other interventions.
Right.
Please watch this video and others on CVI YouTube channel. This is Chadi from Denver, Colorado. Rahul, thanks so much for your time.
Thank you.